Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Transcatheter Heart Valve Therapy. If I have yet to meet you, I am a former patient, and I am the guy who started HeartValveSurgery.com about 10 years ago. Our mission at the website is really, really simple. We want to educate and empower patients who have heart valve disease. And this webinar, which has had over 350 registrations from patients in countries all over the world, was designed to support that mission. Just so you know, during the webinar, all the participants will be in listen-only mode. And that being said, you may submit questions during the webinar. You might notice in the upper right-hand side of your screen, there could be a control panel. And that's where you can submit your questions. And what we will do is we'll do our best once we get to the Q&A section of the webinar to answer your questions. The last thing that we're going to do is we're going to have a very quick survey, and we're going to ask you to complete it at the end of the webinar. It's just 5 questions. And so now let's get to the webinar. I am thrilled to introduce to all of you the featured speakers for this session. Dr. Patrick McCarthy is the Executive Director of the Bloom Cardiovascular Institute and the Chief of Cardiac Surgery at Northwestern Medicine in Chicago. Dr. McCarthy has achieved national and international recognition in the fields of complex adult cardiac surgery, including valve repair and valve replacement and atrial fibrillation. He has performed over 10,000 heart operations, of which more than 4,000 of those involved valve therapy. In addition to Dr. McCarthy, Dr. Charles Davidson is on the line, and he's the Medical Director of the Bloom Cardiovascular Institute, and he's the Clinical Chief of Cardiology at Northwestern Medicine. Dr. Davidson has several areas of expertise, including valvular heart disease, coronary angioplasty, and adult congenital heart disease. Dr. Chris Malazri is an attending cardiac surgeon at Northwestern Medicine and Associate Director of the Center for Heart Valve Disease. Dr. Malazri's clinical interests include aortic valve replacement, bicuspid aortic valve disease, valve-sparing aortic root replacement, and aortic arch reconstruction. I could go on and on about the careers and the achievements of Dr. McCarthy, Dr. Davidson, and Dr. Malazri. Instead, what I want to share with you from the heart is that this team is celebrated by our community, and it's for very good reason. Since launching this website, Northwestern has successfully treated over 100 patients from our community. Those folks include people like Robert Winter, Sara Bloomfield, Ron Roven, Gene Cook, Sharon Knickerbocker, Lisa Woods, Mark Croto, John DeFazio, Carol Wright, Charlotte Hartzell, and Debbie Cross. Personally, I am humbled that Dr. McCarthy, Dr. Davidson, and Dr. Malazri are taking time away from their very busy practices at Northwestern to share their experiences and clinical research during this educational webinar. So to start, I'd like to turn controls over to and introduce you to Dr. Patrick McCarthy.
Thank you, Adam. And first of all, I want to thank you and all the people that are involved at HeartValveSurgery.com because it's such a great reference for our patients, and you really take the time to get it right, and I know they really appreciate it, and it's great for me to see the pictures of our old patients that we know so well from Northwestern. So, Adam, if you could go on to the next slide. When we had talked about what we want to talk about for this webinar today, we wanted to focus on one of the most revolutionary areas in heart disease that I've seen in my entire career that spans decades now. 10 years ago, the topics that you're seeing listed there under overview about replacing heart valves without surgery, transcatheter mitral valve repair, and tricuspid valve repair, we weren't even talking about them. They weren't at our meetings. We weren't considering it for patients. It wasn't anything that we discussed. So in the past 10 years, there's been this revolution. And as you'll hear from Dr. Davidson and Dr. Malazri, now we have commercially approved options and then a variety of new devices that are undergoing early experimental work. And so with that, my partners, Dr. Malazri and Dr. Davidson, are going to walk us through some of those newer options for patients. And Dr. Davidson, one of our interventional cardiologists and medical director of the Bloom Cardiovascular Institute, is going to do the first group.
Thank you, Pat.
We have the next slide.
Thank you, Pat, and thanks, Adam, for hosting this today. It's a good opportunity to kind of start with some basic anatomy to educate the audience here. And so the heart is basically a large pump or large muscle, if you will, in the body that pumps blood out through the aorta to the rest of the body and receives blood from the head and neck and the rest of the body up through the right side of the heart. And if Adam, you go to the next slide, kind of does a nice cross-section of the heart and shows what the inside of the heart looks like. As you can see, the red part of it is primarily the muscle. Right down the middle is the septum that divides the right side of the heart from the left side of the heart. And the white structures are the valves. And Adam, if you go to the next slide, I think it actually shows it better. So on the top part of the screen, you see the left ventricle. That's responsible for the main pumping chamber of the heart, which pumps blood out then through the aorta and through the aortic valve. And on the right side of the heart, that's where the blood is received from the rest of the body and is responsible for returning blood to the lungs to get oxygen to then come back to the heart. So next slide gives a little more detail. So in order to regulate the blood flow throughout the heart has a series of valves that open and close in order to regulate the flow from the top part of the heart to the bottom part of the heart and then out to the lungs, and then back from the lungs into the top part of the left side of the heart to the left ventricle and then out to the aorta. And what we're going to discuss today are primarily the aortic valve, the mitral valve, and the tricuspid valve. The tricuspid regulates the right atrium to the right ventricle, the mitral valve from the left atrium to the left ventricle, and then the aortic valve from the left ventricle out to the rest of the body. And then I think we can go to the next slide. So traditionally, open heart surgery was the only way to take care of patients who had degeneration of their aortic valve, typically called aortic stenosis. And approximately 8 years ago in the United States and about 10 to 12 years outside the United States, there was, as Pat said, a revolution in therapy which allowed replacement of the aortic valve with catheter-based therapy, so that most often can be done through a artery in the leg. And so if we turn to the next slide, this is again kind of reviewing what we showed you earlier. Aortic stenosis involves blocking of the aortic valve, which regulates the flow from the left ventricle to the rest of the body. This blockage is typically caused by a calcium buildup. It's really not related to your lifestyle. It's not related to your cholesterol levels. And really it's just wear and tear of the valve over time where calcium builds up and then obstructs flow out through the heart. We do know that without treatment that this can be a fatal condition, and the medications are only partially effective as they relieve the symptoms but don't actually relieve the obstruction that can lead to problems with heart failure and eventually death. Okay, let's go to the next slide. Maybe somebody can go on mute there, I think, because there's a little echo I'm hearing in the background. No? Okay, we'll just keep going. So aortic stenosis, what are the problems with that? Again, this is a lot like plumbing, and if you think about it, you can use Drano, which are the medications for a while, but after a while that doesn't work and you have to do a replacement. And what happens? You develop high pressures in the left ventricle, the main pumping chamber. That causes blood to back up throughout and into the lungs, causing things like heart failure, shortness of breath, breathing problems, edema, chest discomfort, and often passing out if it's really severe. This also causes thickening of the left ventricle, so the ventricle becomes what we call hypertrophied because of the extra pressure it's having to exert to eject blood. And then over time, the muscle cannot thicken any further and the heart begins to weaken and dilate, and that's when we see even more symptoms of heart failure to develop. But the heart doesn't actually have to weaken to even cause the heart failure. Even the thick muscle has trouble dealing with the extra load against the heart. And as I said, the symptoms most commonly reflected are shortness of breath, chest discomfort, and lightheadedness or true passing out, which we call syncope. Next slide. So these transcatheter heart valves were developed to, again, try to treat patients initially that were not candidates for surgery, and we'll talk about how that's changed, where we've gone into more intermediate risk patients and now into low risk patients, and Chris will speak to the low risk population. But as you can see, there's been an evolution in these heart valves, and initially the first one on the left there was the Edwards Sapien valve. It was a fairly high profile valve, but it was a good chance to show that these can be used and were feasible and were effective and did save lives for patients. as we moved across the spectrum, we're now into our third generation of the Sapien 3 valve, which really has some unique characteristics down near the bottom where you see the white there in the Sapien 3. It actually has a skirt that assures that we get a good sealing around the valve when it is placed into the body. The other advantage of this is it's made of a cobalt chromium metal rather than stainless steel, so that it's lower profile and therefore is a smaller hole and easier to deliver, makes the procedure go more smoothly, and has helped in reducing complications from the procedure and improving outcomes long term. And down the bottom, you can see the evolution of the Medtronic core valve, which is a nitinol frame device. This is a porcine valve, so a pig valve. The one, the Sapien, is a cow valve. We can talk about those differences a little bit later on, but this is a self-expanding valve, so kind of a different technology, but both have been shown to be safe and effective in patients with intermediate and high risk for surgery. And again, the low-risk trials are ongoing for both devices right now. So if we go forward, please, Adam. Thank you. So we're going to show this animated video, and I think this is kind of highlights how we perform these procedures. This animated video will be shown using the Sapien 3, but it's fairly similar for the core valve, at least some of the aspects. There's a sheath or a plastic tube placed into the groin through the femoral artery, and then a wire that's been put across the stenotic aortic valve is in the left ventricle, and then a balloon is inflated right here, and that gives us some partial opening of the valve that then allows us to then do the valve implantation. So this is kind of a preparation of the valve in order to do the actual valve implantation. So that balloon is then withdrawn over that same wire, and then going through that same plastic tube, we bring in the delivery system for the stented valve, and this one being the Sapien 3 valve. When we put it into the descending aorta, as it is here, we mount it over the balloon. That's the preparation of the valve. Some of it is done outside the body, and some of it is done inside the body, as you can see here. Once we have it placed over the balloon, we then bring it over the same guide wire, then across the aortic arch, and then we will place this across the stenotic aortic valve, and you can see in this valve's got some calcium deposits as shown in the cartoon. So it comes down across, and these cross very nicely now. In the early days when they were larger profile, a little more challenging to get across, but then we unsheath it. So then now we have this valve mounted on the balloon. We get the heart pumping at a fairly rapid rate so that the blood pressure goes a little bit lower in the body and allows us to very precisely position this valve. We want to put it to the exact location where we can get maximum valve function and also prevent any leaking around the valve. And then this is then inflated, and the valve is implanted in across the old valve. This is all done under X-ray guidance. At Northwestern, we do most of our patients today with conscious sedation. They don't even require general anesthesia anymore. It's done in collaboration with cardiac surgery and interventional cardiology. We do all of these together, and we've done over 600 of these now with excellent outcomes, and even more importantly, with great collaboration among the specialties, trying to design the best therapy for the patients. The valve becomes immediately functioning. At that point in time, blood flow is then regulated by that new valve. The old valve, again, has been pressed aside, and competency of the new valve. And at that point, the sheets are withdrawn from the body, and we use some stitches to close the artery without actually doing an open of the femoral artery. About 90% of people can be done from the femoral artery. About 10%, because of small arteries, will have to be placed in a different way through usually an artery in the armpit area. I think we can go to the next slide now, Adam. So this is showing you an actual procedure. This is now under fluoroscopic guidance, X-ray guidance. We do an aortogram. That was a little puff of black there. Now you can see the balloon being inflated and the valve being positioned permanent in its location across the native aortic valve. Again, all done under X-ray guidance. That's the valve being implanted. I think we can go to the next one. And so this is typically how it looks after it's been implanted. We then do an aortogram with some contrast dye to evaluate to make sure the valve is functioning properly. There's no leaking around the valve. If there is some leaking, we can inflate it a little bit larger as needed. We also, not shown here, will do a transthoracic echo, meaning an echocardiogram on the chest wall to verify that the valve is functioning properly. So we get 2 assessments of the valve before we leave the room to make sure everything's okay. Next slide. So how does this valve perform? Like everything, nothing's perfect, but I think what's really exciting, if you see where we started, where it says P1B TF, that's our very early experience, which I think now we've been doing these with Chris for almost 8 years now. Yep. And you can see that in the early going, you know, mortality at 30 days was a bit higher, was 6%. Now remember, these were patients that were extreme risk, so they were essentially not eligible for surgery. They really had no option, and so we thought that was good, but you know, we want to do better than that. The exciting part, I think, for all of us that have been involved with this technology, if you move to all the way over the right side of the slide, you'll see that mortality rates have now dipped into the 1% range. So now we really have both a durable treatment and a safe treatment for patients that I think rivals, at least in these populations, again, intermediate risk, cardiac surgery, and we'll show you a next slide, if you will. So what we recently demonstrated in one of the studies that we participated in was the Partner 2A trial, which looked at patients in intermediate risk. That means their surgical risk was calculated to be between 4 and 8%. So the risk of dying within 30 days based on a calculated risk was 4 to 8%. And so what we did was patients were randomized to surgical aortic valve replacement or transcatheter valve replacement. And if we go to the next slide, these are data that were published in the Lancet, which is one of our most prestigious medical journals, showing mortality all the way out to 12 months. And if you looked at the surgery group shown in the light purple, it was 13%. And if you looked at the valve in patients that got the transcatheter valve replacement, it was 7.5%. So, you know, these I think, were fairly impressive data. Even if you look at the 30-day data, again, earlier in the left side of the slide, it was 4% for surgery versus, as I showed you earlier, 1% for transcatheter valve. So both early and late mortality seem to be benefited by the use of the transcatheter valve in this intermediate risk population. So obviously this begs the question, how will this perform in a low risk population, patients who have a calculated surgical risk that's less than 4%. So more of what we would say the all-comers population. And that's where I'm going to turn it over to my colleague, Dr. Malaysia here, to go through what we have to offer in that population right now.
Well, thanks, Dr. Davidson. And Adam, thanks so much for having this webinar for our patients. I'd like to start by telling this group about a very exciting group of trials that are coming up and ongoing at this point. We can go to the next slide, Adam.
Let's skip to this one. Let me go to the next one, Adam. We'll just skip this one for now. Yep.
So given that TAVR is a standard of care and commercially available for very high-risk patients, well, what about the vast majority of patients that are low risk? This is the basis of 2 ongoing trials in the United States studying TAVI for low-risk patients. So what does this mean for the average patient? Well, if you're a low-risk patient with aortic stenosis, who would otherwise just go ahead and have aortic valve surgery, which is a great option, you may be a candidate for enrolling in this trial and possibly getting a TAVI procedure. The purpose of the Partner 3 trial, which is a trial that we're enrolling here at the Bloom Cardiovascular Institute at Northwestern Medicine, is to find patients with severe calcific aortic stenosis. Secondly, these patients should be low operative risk for standard surgical aortic valve replacement. Next slide. Now, patients that are candidates for this trial will get one of 2 therapies. The first is standard aortic valve replacement, seen to the right here. The other will be the transcatheter valve replacement, or TAVR. This procedure is under study for low-risk patients. Next slide. Now, if you randomize in a group that get aortic valve replacement, this is an excellent operation for patients who are low risk for aortic stenosis. And for most centers, including ours, this could be done through a minimally invasive approach, through a keyhole incision with a cosmetically appealing scar. Next slide. The study group is the TAVR group, so the transcatheter aortic valve replacement group. And this is the procedure that Dr. Davidson had previously described to you in high-risk patients, now being studied for patients with low risk for aortic valve replacement. This procedure can either be performed through the groin, which was seen on the animation, or it can be done through a transapical procedure through a small incision below the left breast, or through a transaortic procedure, also through a small incision through the upper right chest. Next slide. In addition to the low-risk trial, we're also studying very specific subsets of patients. So this procedure called valve-in-valve procedure, transcatheter valve-in-valve procedure, is meant for patients who have recurrent valve disease secondary to failure of a previously implanted tissue valve. Now, when patients have an aortic valve replacement, we certainly hope that they will have a durable replacement for a long time. However, some patients do outlive their tissue valves. So this therapy is meant for that group of patients. Next slide. Now, it's interesting to note that we can do a valve-in-valve procedure in a previous surgical valve that is either too tight or too leaky. And this is what we see in real life when we implant a Medtronic valve in a patient who had previous aortic valve replacement. Currently, this procedure is approved for patients who had previous surgical aortic valve replacement who now need a new aortic valve. Next slide. What's currently under investigation is whether or not this therapy will also be good for patients who've had previous mitral valve replacement who now need a new mitral valve. This is currently being performed in select centers in a off-label approach, meaning that the FDA has not specifically approved this device for this procedure, but it's been shown to have very good outcomes in select patients. This is a good segue to the next segment of the talk. Next slide. Discussing transcatheter mitral valve repair and replacement. And this is for the group of patients who have mitral regurgitation or a leaky mitral valve. Next. Mitral valve regurgitation happens when the mitral valve leaks and when the heart beats, instead of the blood going forward into the body, it goes backwards towards the lungs. This causes symptoms such as, next slide. Next slide. Next slide, we'll go back a little bit. But, this causes symptoms secondary to weakening of the left ventricular muscle, otherwise known as heart failure, elevation of blood pressure in the lungs, otherwise known as pulmonary hypertension, atrial fibrillation and the risk of strokes, and also tricuspid valve regurgitation. Go backwards 2 slides, please, Adam. This is what we see in surgery when we look at the mitral valve. It's a valve with 2 leaflets. Next slide. Now, why do patients have mitral regurgitation? We broadly classify mitral regurgitation in 2 very large groups. The first group is the group of patients that have a primary problem with their mitral valve. We call this primary or organic etiology. And the majority of these patients have what we call degenerative mitral valve disease or mitral valve prolapse in common language. The second group of patients has mitral regurgitation not because of the mitral valve, but secondary to heart failure. And this is what we call functional mitral valve regurgitation. Next slide. Next slide. Now, traditionally, we will repair mitral regurgitation secondary to degenerative mitral valve disease with excellent results, complete resolution of mitral regurgitation, standard through a sternotomy. Occasionally, we can do these procedures through a minimally invasive approach to the right chest. As you can see, this lady has a small incision tucked below her right breast, which is also very cosmetically appealing. Next slide. Now, there are a group of patients who will not tolerate open mitral valve surgery. So here comes a great application for transcatheter procedure. This is a device called the Abbott MitraClip. It uses a procedure that is used also in open heart surgery, and it's meant for patients who are not candidates for open heart surgery. Here you can see a catheter within the heart. The mitral clip is loaded on the end of this tube, and with careful positioning under echocardiography and X-ray, we could advance this clip into a position right between the two leaflets. Here the cartoon is showing you how the mitral valve is leaking backwards. Once we advance the clip into the left ventricle, this clip can then grasp the two leaflets right down the center. If we don't like this position, we can always release and re-grasp the mitral valve in order to get the perfect position with the most reduction in leakiness of the mitral valve. This is a completed mitral clip procedure with a clip right down the center between the two leaflets, successfully reducing the mitral regurgitation. Next slide. Now, a final very exciting group of procedures that can be done with a transcatheter approach is a complete mitral valve replacement without open heart surgery. Currently, these devices are under investigation, meaning that they are not FDA approved. We've had the opportunity to participate in this trial and deploy this device with very good success. Go ahead and play the video. Again, this procedure is done all within the heart and the vessels. This particular device has a valve inside a plastic tube, very similar to the TAVR procedure, but meant for the mitral valve. This valve is asymmetric, meaning that it's a D-shaped valve. We have to position it in the perfect position in order to make this work. This is done under echocardiography as well as X-ray. Once this valve is in position, we can deploy the valve where it becomes immediately functional, completely abolishing the leakiness of the mitral valve. Next slide. So the summary, transcatheter mitral valve therapy is a therapy meant for patients with mitral regurgitation or leaky mitral valves. Most patients will do very well with open heart surgery. Occasionally, minimally mitral valve surgery will be an option for some of these patients. For patients who are too high risk, we have transcatheter therapies available. The one that is currently commercially available and FDA approved is the MitraClip procedure for leaky mitral valves. We are currently investigating trials using a complete transcatheter mitral valve replacement, which is a very exciting therapy we hope to see in the next several years.
Thank you, Chris. Adam, let's go to the next slide. I know we're kind of hitting you with a lot of rapid-fire technologies here and treatments, but I want to kind of try to cover the breadth of therapies that are evolving with transcatheter approaches to valvular heart disease. The next one to cover is the transcatheter tricuspid valve repair. If you go to the next slide, just to refresh your memory from the earlier anatomy lesson, the tricuspid valve regulates blood flow on the right side of the heart between the right atrium and the right ventricle. Once again, if there is leakiness in this valve, it causes blood to accumulate primarily in the extremities and causes problems with fatigue, shortness of breath, heart failure. Can also lead to right ventricular failure if it dilates too much as well. So another valve that when it's in trouble can cause symptoms and can eventually lead to survival issues with the patients. This is a valve that some people have called a forgotten valve because it's more on the right side. It typically causes a lot of symptoms, often managed by medication, and surgery is not often offered as a sole therapy for this valve. Most of the surgery that's done with the tricuspid valve is done in relation to a mitral valve, let's say repair and a tricuspid repair at the same time, or aortic and tricuspid at the same time. So it's done in combination, but as a sole therapy, not often performed. The people that had previous mitral valve therapy, if the tricuspid was not addressed at that time, over time that valve may become diseased. So let's go to the next slide. So what are the symptoms? So when we talk about functional tricuspid regurg, it's a lot like Dr. Malaysia was explaining with mitral regurgitation. There's kind of several mechanisms, and functional means that the heart has dilated to some degree, and the three leaflets of the valve are not collapsing well, and so therefore there's leakiness, and this causes the pulmonary disease and right ventricular dysfunction that we talked about, and this makes up about 80% of patients with tricuspid regurgitation. These are some of the other causes, just for your understanding: chronic atrial fibrillation, prolapse, rheumatic heart disease, leaflet restriction from ventricular pacing leads, endocarditis, and a very special group of patients have had cardiac transplantation and multiple right ventricular biopsies. Next slide. This shows you what happens with mitral regurgitation over time, and these are called Kaplan-Meier curves. As physicians, these are how we assess therapies, we assess outcomes from medical treatment, and just understand disease states. So the top graph, where it says no TR, is looking at patients that have no tricuspid regurgitation and what is their survival out to 1,500 days, approximately 5 years, which are very high survival. And I think what's important here is you drill down to mild, moderate, and then on the very bottom graph, people with severe tricuspid regurgitation, you can see that their life expectancy is markedly diminished by almost 50% when they have severe tricuspid regurgitation. So it doesn't just have consequences regarding symptoms, but may also have prognostic consequences as far as survivability. So next slide. So what has been recently developed are some transcatheter approaches to treat severe tricuspid regurgitation. The one that we've had experience with, and the one that's been most widely studied at this point in the United States and elsewhere, is called the TriAlign device. What this does is put some sutures into the tricuspid valve, and very much mirroring a surgical technique called the K procedure. It essentially becomes a bicuspid valve, which was once a tricuspid valve, and therefore decreases the regurgitation by providing better coaptation of the leaflets. Next slide. So we've had the opportunity to be one of the first in the U.S. It was actually the second center in the U.S. to perform these procedures, and only I think about the fourth in the world to do this. This is done through a neck vein. The catheter gets placed down across the tricuspid valve. A wire then goes through the tricuspid annulus, and then two pledgets are placed down, one on the ventricular side of the annulus and then one on the atrial side. This is a procedure that's guided also by fluoroscopy and echocardiography. Then a second pledget is then placed into the anteroposterior annulus, again on both sides of the annulus. It's drawn together, pulled together, which we call plicating the pledgets, and then the suture is then tied off and with a staple and then removed from the body. And what you can see is what this has done is created a bicuspid valve from a tricuspid valve and improved the coaptation. And we can assess this at the time of the procedure. And the nice part about this procedure, it does allow for some customization, much like the MitraClip. If one suture doesn't work, you can potentially put a second one in, and we have had the opportunity to do that. And again, was in that situation, we're the first center in the U.S. to do two pairs of pledgets for tricuspid regurgitation. So this is also investigational, being done in a non-randomized registry in the United States right now in what's called a feasibility trial. The randomized trial will be beginning at some point, but right now, where any patient with this disease that is not doing well with medical therapy can be at least considered. There are certainly anatomic characteristics that we're looking for in order to assure good success for the patient that we can evaluate based on an echocardiogram for that patient. So I think that takes us through most of our planned procedures and presentation, today. And now I would like to leave time open for questions, and I think Dr. McCarthy, Dr. Malaysia, and myself will be available. And I think, Adam, you have some planned questions that people have submitted already today.
Yeah, Dr. Davidson, and before we get to them, I just want to thank you guys again for sharing all this incredible information. I'm just blown away by all the technologies that you've been collaborating with the various medical manufacturers and the device teams to come up with these transcatheter approaches. It really is amazing to see. And so we are going to move on to the question and answer section. We've got, yes, Dr. McCarthy.
Just before you move on, I just want to make a kind of very high-level comment for the patients back home, and it's apropos this year in particular. Many years ago, I saw a patient with heart failure who really needed to be treated for aortic stenosis. Turns out she was 101 years old, and so surgery obviously would have been very high risk. She had a TAVR, and I'm pleased to report that in August this year, she turned 108. And so, yeah, that's a remarkable story. So you saw a lot of detail and all, but truly this is revolutionary stuff. And it also happened to be 108 years since the Cubs had won the last World Series. So she's seen it all.
That's excellent.
And they were down 3-1. I was saying I don't know how many more years we can expect out of her, so I'm really counting on the Cubs to pull through this time for her. 108 years.
Yeah, congratulations to you and your city on that one. And so getting to the Q&A section, again, you've got a control panel on your screen. Feel free to provide any questions that you'd like answered. We're going to do our best here in a rapid-fire section of this webinar to answer your questions. And we've been getting questions, I got to tell you, for several days now. We've got many on the webinar, so let's get into it. The first one comes from Jim, and it's a great question. He writes, I'll be 80 in March. Congratulations, Jim. I play golf and tennis twice per week. I've had 2 bovine aortic valves implanted. If I need a new heart valve, can I have a transcatheter valve?
Adam, this is a great question. I'll take this. This is Chris Malacery. Congratulations on playing golf at the age of 80. We certainly hope that your new bovine aortic valve will last you for the rest of your life. The question is whether or not we can do something about it if you happen to outlive that valve. I think for this particular case, if the valve fails over time, this would be a great case to do an aortic valve-in-valve procedure. So aortic valve-in-valve procedure is a transcatheter procedure, TAVR procedure. The good news is it is commercially approved for high-risk patients. So I think someone who's 80 years old with 2 previous cardiac operations will certainly qualify. So I think that you'll be able to enjoy a good life out of your second valve. But if it does go bad, the aortic valve-in-valve procedure will be an excellent procedure for this patient.
And Dr. Malacery, for the patients on the line, maybe you can compare and contrast the potential patient benefits for a patient who's going through a surgical procedure versus a valve-in-valve. Maybe if you could talk about maybe pain associated with the procedure, time in the hospital, all the other things that maybe patients and their caregivers who are on the line would want to know about a valve-in-valve.
Correct, Adam. So I think the most striking feature of the TAVR procedure is the very short recovery time. Patients who have a TAVR procedure, in this case an aortic valve-in-valve, can expect to have this procedure with no general anesthesia. Average length of stay in the hospital, about 3 days. The majority of these patients go directly home, do not need to go to rehab, and would likely, for this patient, be able to start playing golf again in about 4 weeks. This is compared to open heart surgery, where we'd expect maybe about 5 days in the hospital and about 6 weeks of recovery time for the sternum to reheal.
All right, great comparison there. It's from the patient, just sounds like a great alternative if it's available for them. And so let's keep going. The question is from Robert, and this is a real interesting one because many patients in our community have abnormal heart rhythms or atrial fibrillation. And Robert asks, what about the use of these types of devices for patients with AFib?
So, Adam, I'll take that. I think it was last year that our webinar focused on mitral valve disease and atrial fib. And when we're there to do mitral valve surgery, we also treat the atrial fib. It's a little like plumbing and electrical problems, though. They're different. And so these devices themselves do not treat the electrical problem, which is the atrial fibrillation. When we're there at surgery, we treat both the plumbing and the electrical problem. But most of these would not preclude the idea that someone could have the plumbing fixed, and then there's different ways of treating atrial fibrillation with a catheter. And so, you know, they could still work hand in hand.
So then, if I understand it right, Dr. McCarthy, there could be it almost sounds like a double catheter procedure, one for the valve and also one for the AFib?
You would fix the valve with one procedure and then treat the patient for a while, and at a different procedure, they could potentially be candidates for a catheter-based ablation of the atrial fib.
Got it. All right, let's keep going. Question from Fernanda. The question is, why is TAVR not recommended for a 60-year-old male with severe aortic stenosis who is otherwise healthy? And the follow-up is, and we've kind of talked about it, what is the benefit to have an open heart surgery compared to a TAVR?
This is another very pertinent question for 2016. Currently, devices that are approved for high-risk patients in their first and second-generation devices. Now, only recently have third-generation devices become available, which we think are going to be good enough for low-risk patients such as this, so a 60-year-old male with severe aortic stenosis. So this is the basis of the low-risk trials that are going on currently with the Edwards Sapien 3 valve and the Medtronic core valve Evolut R. Now, it's important to note that aortic stenosis is not aortic stenosis in every patient. Some patients have aortic stenosis because they have a congenital problem which they were born with. The most important to think about is bicuspid aortic valve. So in this particular patient, it'd be very important to know whether or not the patient has a bicuspid aortic valve, because up to about 50% of patients with bicuspid aortic valve will also have a coexisting aneurysm. In these particular cases, open heart surgery will be a better procedure to address both the aortic stenosis and the aortic aneurysm at the same time.
Great, and we're going to veer a little bit from the questions on the slides, and we're going to go to a live question that just came in from Dean, and this is actually very near and dear to my heart, considering I had a Ross procedure. But Dean writes in, I had a Ross procedure 17 years ago, and wondering about TAVR for pulmonary valve replacement. Is that possible?
So this is Charles Davidson again. In fact, it's a great question, because that has just recently been approved by the FDA for homographs in the pulmonary artery, and also for pulmonic valve degeneration from a bioprosthetic valve. And it seems to be a good option. I would say that the body of data, because this is a less frequently diseased valve, is less than we have from the aortic valve disease population, but seems to be also a fairly safe procedure, with at least with the durability data we have thus far, seems to be excellent, and can be also done transcatheter. It's usually done from a vein in the leg, can be done from a vein in the neck, and it's placed across the existing homograft or bioprosthetic valve. And some of that depends on the dimensions, and make sure that it can be, we have the right size valves and all. But it is an option that should you need that, should be explored with a good heart team like we have here at Northwestern, where we're really trying to customize the therapy for what's best for the patient. I think something I didn't get a chance to emphasize is that all of the decisions on whether we use a transcatheter or whether we use open heart surgery with these patients is really decided by the team for what's best for that particular patient. That there's not a treatment that's necessarily going to be ideal and applied to everybody. We obviously like to favor the non-invasive or less invasive method, but on the other hand, that may not be the best answer for all patients.
Great, and let's keep moving. We've got time for about one or two more questions. We've got a lot of them here. Here comes a question from Mel, which is, would you please ask if the TAVR procedure will be covered by Medicare?
Well, there is some good news here, and that is that CMS, Medicare, does cover TAVR procedures, both the commercially approved indications and also the ones that are involved in clinical trials. So this low-risk population right now is being covered by CMS or Medicare, and obviously patients with intermediate or high risk are also covered. And the same thing is true for the mitral clip procedure. So any investigational IDE trial that we talked about, the TriAlign one for being another one, that would also be covered by Medicare as well.
Great, and here's a question from Sara. She writes, can these new procedures also be performed on a patient who needs a re-repair on a mitral valve where there may be old scar tissue?
I guess I'll take that one. So I would say that's a maybe. It's going to depend on the age of the patient and other medical conditions and what the status is on that mitral valve. Theoretically, it's possible. It's not always necessarily the best choice, however. If it's a very young patient with a valve that could be re-repaired, then that's probably going to be the safest and most durable procedure. The TAVR that we had talked about was really about the last. Can you hear me, Adam?
Yeah, I can hear you now.
There was some interruption. So the TAVR was really sort of the last 10 years as that rapidly developed. The next 10 years, you'll actually see or hear about a lot more developments in mitral surgery, but it's still pretty early doing transcatheter treatment of mitral valves. But theoretically, for some patients, this is definitely a possibility instead of a second operation.
Great. I hope that helped you, Sara. And let's move on. A question from Miles over at Facebook, and this was echoed by some folks here who have submitted questions, which was, I think the real question is, how long will these new valves last?
So that's an outstanding question. I'm going to answer it in several ways. These are the cow valve that's being used, at least the valve itself, is very similar to the surgical valves. However, it is being mounted on a stent rather than a surgical ring. And so what we've tried to do is try to understand what the durability is. And to date, we have some 7-year and even some early 10-year data that are comparing head-to-head with surgery that look to show a similar durability. Having said that, though, we do not have really good long 15-year data, 20-year data that we do have on surgical valves. So I think some of this is unanswered. It looks favorable at this point in time, but we don't have that direct head-to-head comparison, but those studies are ongoing, and as we continue to collect data, it seems to be indicating similar durability, at least at this point in time.
And to follow that question up, and I think this will be maybe the last question if we have time, is the concept several times during this webinar, Dr. McCarthy, Dr. Davidson, Dr. Malaser, you brought up the concept of clinical trials. And what that means not only for figuring out how these new valves and technologies work, but how they can advance medicine. For some of the patients on the line who may have not known what a clinical trial is coming into this webinar, could you maybe spend a minute or two talking about what a clinical trial actually is and how it's used to learn about these technologies?
Charlie, you want to take that?
I'm sure I'd be happy to. So clinical trials are ways in which we try to understand whether new technologies or new pharmacologic treatments are either benefiting or not benefiting patients. And typically, as in most of the ones in the U.S., not all, but many are done through industry-sponsored trials because they're trying to test whether their device or their medication is of benefit compared to traditional therapy. So what happens at that point in time is that they work with the FDA to design a study that would help prove either the benefit and so the things we're looking at are safety and efficacy of the device. And those are the typical endpoints we looked at. And so In these studies, we'll look for like 1 year or 2 year. Patients are often randomized to one treatment, which would be the standard therapy for those patients, versus the new investigational therapy. And then we look at what their outcomes are in the short term and in the long term. Sometimes studies are done as a clinical trial registry, which we talked about some of this valve-in-valve type work, for example, where the FDA has agreed that if you can show safety and efficacy without randomizing to a control group, that they would also be willing to potentially approve it. So once all of the data is collected on this, the clinical outcomes, how the patients have done, safety and efficacy, that's presented back to the FDA. FDA then reviews this with a group of experts and decides whether the therapy has met the expectation that it can be approved for general use and commercial use in the United States. And that's kind of your general industry-sponsored clinical trial. There are some studies that are also sponsored by the government, which we call NIH trials, National Institute of Health. And they're done in similar ways, but have a different sponsorship compared to an industry-sponsored trial.
Great. And well, with that response, we're going to go ahead and conclude the Q&A section of the webinar. But please don't exit the webinar just yet. On behalf of the entire community at HeartValveSurgery.com and all the patients with valve disease around the world, I would like to extend an extraordinary thank you to you, Dr. McCarthy, to you, Dr. Davidson, to you, Dr. Malasry, for sharing all of the work that you're doing, your expertise with us today. And as we end this webinar, I'd like to thank all the attendees on the call. You are part of our community. It's been great getting to know you, many of you recently and many of you over the years. And I just want to thank you for being a part of this community. And lastly, as we conclude the webinar, if you could spend just a minute to complete a very quick survey that is about to appear on your screen. And so with that, I just want to thank everybody again. And as we always say here at HeartValveSurgery.com, keep on ticking. Thanks so much.